Hi, NEET PG 2025 surgery recall session. We are going to discuss from Dopamine, Dr.K.Vinayak Senthil, and I am a cardiothoracic and a vascular surgeon. Have trained more than 3.5 lakh PG aspirants to achieve their PG seat of their choice. In my opinion, this paper is a moderate difficulty paper, but all the questions are from the template and the framework of questions prescribed for a NEET PG or an NEET PG. So it is well within the standards and well within the topics that have been discussed in Dopamine PG search. NEET PG 2025, the surgery questions are taken from three standard textbooks. Number 1, Schwartz textbook of surgery 11th edition, Bile 20th edition, and Subiston 21st edition. Let us go through the questions. Question number 1 reads, a newborn with breathlessness and the chest X-ray given, what is the diagnosis? If you could look into the X-ray, you are able to see lot of bowel loops in the left hemithorax. So it clearly goes with the diagnosis of a congenital diaphragmatic hernia. Congenital diaphragmatic hernia is a very important entrance exam question, and the most common congenital diaphragmatic hernia is Boak-Dallek. The most common will be Boak-Dallek hernia, and this Boak-Dallek hernia is a posterolateral defect. They'll ask you this question. So congenital diaphragmatic hernia are of two types. One is a posterolateral defect onto the left, and the next is the anteromedial defect onto the right. So posterolateral defect onto the left is the Boak-Dallek hernia, and the anteromedial defect onto the right is the Morgagnian hernia. The most common is the Boak-Dallek hernia. The most common presentation of a congenital diaphragmatic hernia is a scaphoid abdomen, and the child presents with a respiratory distress and dextrocardia. So this is the classical triad. One of the most important assistance required for the congenital diaphragmatic hernia could be ECMO, because the child will be suffering from pulmonary hypertension. Yet another question is always asked in PG entrance examination is this: the most important prognostic indicator for a congenital diaphragmatic hernia is pulmonary hypertension. So you will treat pulmonary hypertension first, reduce the pulmonary hypertension, then do the anatomical repair, reduce the hernia, and repair the defect of the diaphragm. Is that clear? So this is exactly what is given in Schwartz 11th edition, page number 1712. The X-ray shows air-filled bowel loops within the left hemithorax, causing a rightward mediastinal shift and compression of the left lung. So it's the Boak-Dallek type. It's the most common type of congenital diaphragmatic hernia. Is it clear? Yes. Second question reads, a patient with jaundice, anorexia and weight loss since 2 months, and the gallbladder is palpable, soft and non-tender. What is the likely diagnosis? The key words are this: the jaundice, weight loss, anorexia, and the palpable gallbladder, and that is soft. So that means it is about obstruction distally of the common bile duct that is causing dilatation, with the dilatation of intrahepatic, extrahepatic biliary ducts, and also the gallbladder. So the answer goes in favor of carcinoma head of pancreas. Either a carcinoma head of pancreas or periampullary cancer can present exactly similar to this. Okay, a grossly distended gallbladder with jaundice, you should think of a carcinoma head of pancreas. So the treatment of choice for carcinoma head of pancreas or periampullary cancer is Whipple's procedure. What do you mean by Whipple's procedure? It is a pancreatico-duodenectomy followed by reconstruction. What are the reconstruction? It would be choledochojejunectomy, it could be gastrojejunectomy, then pancreatico-jejunostomy. Understand? This is about the reconstruction following Whipple's procedure. Clear? Okay. So this is what exactly given in Bailey and Lau 20th edition, page number 1282. Jaundice secondary obstruction to the distal bile duct. Most common symptom draws attention of ampullary or pancreatic head tumors, especially preferably cancer of adenocarcinoma of a variety. So the patient will have pruritus, high colored urine, and clay colored stool. Typical features of obstructive jaundice. Is it all clear? Yes. Third question reads, post-total thyroidectomy done, which of this complication may occur after 2 to 3 days? Yes, the right answer is carpopedal spasm in this question, because it's because of hypocalcemia. Understand this: hypocalcemia, the cause of immediate hypocalcemia could be hungry bone syndrome. It's a relative hypocalcemia, that the shift of calcium, yes, from because of the previous entity of an hyperthyroidism, could be of a shift of calcium, yes, from the blood back to the bone. It's called hungry bone syndrome. Number 1. If a hypocalcemia occurs 2 to 3 days after surgery of POD, then it is because of hypocalcemia because of parathyroid insufficiency. The most common cause of parathyroid insufficiency is thyroidectomy. And the most common cause is vascular insufficiency. The most important, the predominant blood supply to the parathyroid glands is about the inferior thyroid artery. Okay, those are the key points, right? Now, the deviation of mouth could be a facial nerve palsy. It's most commonly in a parotid surgery. Tension hematoma happens in the immediate surgery, yes, or during the surgery, or immediately after the surgery in the post-operative ward. And recurrent laryngeal nerve will also present with a stridor. Unilateral could go unnoticed, could be asymptomatic, but bilateral presents with inspiratory stridor. So the right answer is corpopedal spasm. This is what is exactly given in Subistent 21st edition, page number 916. After total thyroidectomy, hypocalcemia due to a transient hypoparathyroidism typically occurs in 2 to 3 days, and the key sign is corpopedal spasm along with tingling. The earliest sign of hypocalcemia is perioral numbness, tingling and perioral numbness, and positive Chopsticks or Trocheus sign. Clear? So, understand this, any symptomatic hypocalcemia has to be treated with 10% calcium gluconate in 10 ml of solution over 10 minutes of infusion. Understand? So, the rule of 10. Okay. So, 10% calcium gluconate, 10 ml of dilution with over 10 minutes of infusion. Slow IV correction of symptomatic hypocalcemia. Is it okay? Yes. Let's move on to the next. Question number 4 reads, a 25-year-old patient had a road traffic accident, was initially conscious but later becomes unconscious and subsequently died. On post-mortem examination, multiple petechial hemorrhages. Very, very, very classical, especially on corpus callosum. And the right answer is diffuse axonal injury. Diffuse axonal injury is a key entrance exam question. The petechial hemorrhage will be throughout the brain, can be seen in autopsy like this or in an MRI, and most commonly in corpus callosum and dorsolateral midbrain. And the kind of rotational deceleration acceleration force can cause this, especially people who are dive from top, bungee dumping. The rope, they tie the rope in the leg and they fall upside down, a bungee, or could fall from a height, yes, for a stunt, or fall from a somersault in a swimming pool or a diving competition. Those kind of injuries cause diffuse axonal injury. Very, very important. Exactly what is given at Bailey and Love in 28th edition, page number 368. This form of primary brain injury is seen in a high energy accident that usually renders the patient comatose and a poor outcomes. The pathological diagnosis made post-mortem, the hemorrhagic foci is seen in corpus callosum and dorsolateral rostral brainstem, and CT could be suggestive and MRI is more sensitive. Understand this, MRI is more sensitive. Diffuse axonal injury is an important exam question. Histopathologically, also you will see typically axon balls. Axon gets injured, retracts and then swells. So you see axon balls. So very, very important. Clear? Is it okay? Yes. Question number 5 reads, a patient presents with a dry and a blackened fingers. What is the most likely diagnosis? So without giving a background, if this is given, the right answer will be a dry gangrene. Because you will be able to see the line of demarcation, and this can be seen in Raynaud's, it can be seen in frostbite. Any of them is not a wet gangrene but a dry gangrene. But without any of the clinical scenarios in the background, there will be a dry gangrene. And what exactly given in Bailey and Love on 28th edition, page number 999, is a dry gangrene results from arterial occlusion with infection. The dead tissues are black, dry and mummified, and clear line of demarcation is often seen. Typically caused by peripheral vascular disease. You know about the peripheral vascular disease, about the 5 Ps, pulselessness, pain, paresthesia, yes, poikilothermia, and paralysis. You would have heard of peripheral vascular disease, and also heard about TAO, that happens in the lower limb. Thromboangiitis obliterans or Burgess disease, and also heard about the ankle brachial pressure index. It's very, very important. Normal is 1. Anything below 1 of 0.9 is ischemia, and anything by 0.5 is a critical limb ischemia, and anything below 0.3 to 0.5 we can cause rest pain, and below that can cause gangrene. Okay, so very, very important area of peripheral vascular disease is the upper limb or the lower limb. Definitely could be asked in exam. Next question that reads, during the submandibular gland surgery, which of the following structures likely injured? See, here you can see the submandibular gland excision. One of the most common nerve that is closely associated with this is an hypoglossal nerve. So hypoglossal nerve, you need to be really, really, really careful because it is deep inside along with the relation to the submandibular gland, especially the submandibular gland duct. So you should take care of the hypoglossal nerve. The injury of that will cause deviation of the tongue on the same side. So this is given in Bailey and Love on 28th edition, page number 845. Submandibular gland surgery, hypoglossal nerve is identified as a deep to the posterior belly of digastric and superficial to hyoglossus muscle. It runs upwards to forwards and supplying all intrinsic muscles of the tongue and most extrinsic tongue muscles. And careful retraction of the gland and the fascia allows the clear visualization of hypoglossal nerve, the damage to which could cause ipsilateral tongue weakness and deviation. Clear? Yes. Next, a 45-year-old male with the difficulty in swallowing and weight loss and the chest X-ray showing associated bronchiectasis. A patient presents with the X-ray below and it's typical of a swallow, barium swallow, and typically shows a bird's beak appearance. A bird's beak appearance is of nothing but achalasia cardia. Investigation, gold standard investigation is manometry. The normal lower esophageal sphincter pressure is 13 plus or minus 5 millimeter of mercury. And any pressure more than 25 mm of mercury is diagnostic of achalasia cardia. We have three types of achalasia cardia, type 1, type 2 and type 3. There is also could be asked in potential question in the next exam. But aganglionosis and loss of myenteric plexus and tonically contracted lower esophageal sphincter, absence peristalsis, simultaneous contraction, yes, sigmoid dilatation of the esophagus. Patient presents with halitosis, the foul smelling, old food and aspiration, symptoms of lung signs like bronchiectasis, typically of achalasia cardia. One of the most important differential diagnosis is Zenker's diverticulum, which happens in the topmost part of the esophagus, and achalasia cardia happens in the lower end of the esophagus. So today, the treatment of choice has become POEM, peroral endoscopic myotomy. If the facilities are not available, then you can work for laparoscopic Heller's cardiomyotomy. Clear? So this is what is the explanation given in 21st edition of Subistan, page number 1026. The above esophagogram shows dilated esophagus, the distal narrowing referred to as classical bird's beak appearance, and it is of achalasia cardia. Manometry is the gold standard investigation of choice. Failure of relaxation of lower esophageal sphincter. Correct? Now, identify the type of the bile duct injury according to the Strasbourg classification. See, bile duct injury is an important entrance exam question. And what is the type of injury given here? Yes, and this is typically of a minor duct injury, especially of the cystic duct. So type A injuries, or type A injury is a minor duct injury, especially of cystic duct, and type B injury is about the occlusion of the right posterior sectoral duct. And here transection, C will be the transection of the right posterior sectoral duct, and D will be the lateral duct injury of the main CBD. Okay, and subclassification of E1, E2 and E6 is there for your reference. I have posted this in your YouTube and also in your app. You can look into it. So Strasbourg and Bismuth classifications are very, very, very important. Clear? Yes. Now let's move on to the next question. One question on the suture will be asked. Identify the type of suture material. According to this, it looks monofilament. And monofilament and PDS. Okay, polydioxanone, one of the favorite absorbable suture material for the surgeon. Yes, one of the favorite, PDS. The important parameters that you need to look on Bailey 28th edition of page number 106. PDS is a monofilament synthetic absorbable. Okay, it maintains a tensile strength up to 6 weeks, very important number, 6 weeks, and completely absorbed around 180 days, monofilament. So monofilament, the chances of infection is less. Okay, braided infection is more. Clear? And it is absorbable. It is about 180 days. So completely absorbable, good. Yes, this is one of the preferred suture material. And the entire list of suture materials from the catgut to polyglactin, and that is the Vicryl, and polydioxanone and polyglycraptone. I have given you all those details for your reference. Okay. The catgut, this question was also asked in previous exams. Where is the catgut taken from? Where is it taken from? It is taken from the small intestine of the sheep. Understand this, submucosa of the small intestine of the sheep is the procurement of catgut. And the coated agent is called the chromic catgut. Okay. So next was synthetic. Okay. Next was synthetic. Now, question number 10 reads, a mass over the right eye gradually increasing in size over a decade. What is the diagnosis? See here. This is a classical place for a dermoid cyst. This is called external angular dermoid and external angular and posterior auricular. These are the most common areas because these are the suture, fusion of suture lines. So future of suture lines, anywhere in the midline or external angular or posterior auricular. This is the dermoid cyst. Very clear? Okay. and it's like a spotter. So it is given in 11th edition of Schwartz, page number 527. Dermoid cysts or congenital variants occurs as the result of persistent epithelium within the embryonic lines of fusion. Okay, it occurs most commonly in the forehead, nose tip, and most frequent sites of the eyebrow. This is the external angular. Yes? Yes. Now next question is identify the type of knot. And this question is a standard repeat question, and this knot that is given is about the surgeon's knot. Very, very clear. It's a factual question. And surgeon's knot is a surgical knot is a simple modification of the reef knot. It adds extra twist when tying the first row, forming a double overhand knot, and the additional turn provides more friction and can reduce loosening while second half of the knot is tied. Very clear? This is a surgeon's knot. Now the type of fistula. What is the type of fistula A? The type of fistula A is typically of the intersphincteric fistula. It's an intersphincteric, between the sphincter, internal sphincter and the external sphincter. Correct? And you can see rest of all the types. And what are the types? I can show you from Subistan 21st edition very clearly in this diagram. You can see the type 1 is the intersphincteric, what asked in the question. Now the type 2 is the transsphincteric. You see that across the sphincter, both the sphincters. Now if you see the type 3 is suprasphincteric. And type 4, this is the type 4, this is the extrasphincteric. Now there are two types of fistulas that you should know of, is about a high fistula and a low fistula. Understand? And a high fistula, you need to do a set-on suturing, and high fistula has to be converted into low fistula, then to do a fistulectomy. And low fistula, you can do a fistulotomy or a fistulectomy. Fistulotomy is done for an acute fistula, and fistulectomy is done for a chronic fistula. Very clear? So this is what you need to know about the fistula. Very, very, very important exam question. Okay. Yes. Next, move on to the next question. A patient was being operated for a bleeding duodenal ulcer. Surgeon accidentally cut structure posterior to the epiploic foramen, causing a profuse bleeding. Identify the structure was cut. See, the most important is the epiploic. This is the keyword, epiploic foramen. The right answer is inferior vena cava. See, in the epiploic foramen is a connection between the greater sac and the lesser sac. Understand this. Connection between the greater sac and the lesser sac is called the epiploic foramen. Anterior to the epiploic foramen, you will have the portal triad. Anterior to the epiploic foramen, you have the portal triad. Posterior to the epiploic foramen, you will have the IVC. Understand this. So if you have this is anteriorly portal triad and posteriorly IVC, then the answer is inferior vena cava, as exactly given in Schwartz 11th edition, page number 1346. So in surgery, bleeding posterior duodenal ulcer, if sutures posterior to the epiploic foramen accidentally cut, the most likely structure is IVC. Anatomically, anterior boundary is the hepatoduodenal ligament where you find the portal triad. Is it okay? I've given you the key landmarks. Is it clear? Yes. Let's move on to the next. 25-year-old with a 5-year history of the left leg unilateral varicose vein, identify the right statement. See, it's a typical case of a varicose vein, full-fledged varicose vein, and it can progress to eczema and pigmentation. I mean, rest of the things are not appropriate. Most common cause is not pelvic tumor, it's most common is idiopathic, and this is not grade 6, and recommended treatment is not sclerotherapy. This is either has to go for SEPS. The treatment of choice for varicose vein today is called SEPS. Subfacial endoscopic perforated surgery, preferably if it is a perforated incompetence. Mostly looks like a perforated incompetence, but the investigation of choice is duplex Doppler. Understand this. Duplex Doppler. Is it okay? Yes. Now varicose vein leads to chronic venous insufficiency, and that can in turn lead to stasis, dermatitis, eczema, and hemocytin deposition. It's called pigmentation. Understand? So C6 as given in the question, and the option is active venous ulcer. There is no active venous ulcer here, so it will not suit that option, right? Yes. Let's go back to the question. So C6 will not be there, and it's not most common is idiopathic, and the recommended treatment is definitely not sclerotherapy, is for recurrent varicosities. Recurrent or reticular veins. Reticular veins. Understand? Yes. Next question. Let's go on to the next question. The above procedure is done for what? What you could see in this procedure? What is that is seen in this demonstration here? And if the question remains the same, I mean all this are for circumferential burn. So what is all this been? This is called eschorotomy. Yes, because circumferential burn will cause venous return, impedance in venous return, obstruction to venous return or arterial inflow. So that can eventually cause either venous gangrene or arterial gangrene. Okay, so for that, escharotomy has to be done to relieve the compression, so to relieve the compartment syndrome. Okay, either could be the extremities of the leg or the upper limb, whatever it might be. So to prevent compartment syndrome, escharotomies has to be done, and submission 21st of edition clearly gives in page number 492, when deep partial thickness or a full thickness burn encompasses the circumference of extremity and peripheral circulation to the limb can be compromised, and development of generalized edema beneath the non-yielding eschar impedes the venous outflow and eventually affects the arterial inflow also. So you need to do escharotomy. Clear? Yes. Now, a 7-year-old boy presents with a progressive non-retractable foreskin and tends with a perpetual skin, white perpetual skin. What is it like? It's clear cut. It's a clear cut case. If this is the question, exactly the question in the image, and it's called balanitis xerotica obliterans. Yes, balanitis xerotica obliterans is a chronic, possibly an autoimmune perpetual inflammation that can affect the distal urethra and rarely seen before the age of 5. Given exactly in 28th edition of Bile in page number 279. And the treatment of choice for balanitis xerotica obliterans is circumcision. Circumcision. Is it clear? Yes. Next, move on to the next question. Patient presented with the carcinoma anal canal, which is the first node to be involved. It's very, very clear. Superficial inguinal node is the first node to be involved, and the second is go to the deep inguinal node. Most often in the entrance exam question, this is also asked. The treatment of choice for anal canal cancer is called Negros regimen. Understand this. Negros regimen is nothing but chemotherapy followed by radiotherapy. Alternate chemo radiotherapy is called Negros regimen. Okay. So this is a very, very famous entrance exam question. On anal cell cancer, this is the most common is squamous cell cancer. Anal cell cancer is the most common is squamous cell cancer, as given in page number 28th edition of Bailey and Love, page number 1419. Remember, all the questions are taken word to word from these 3 standard textbooks. So a mentor who can have read all this and know everything could definitely help you and support you, and he also knows where exactly the questions can come from. Yes, yes. A 65-year-old male with a stab injury to the abdomen with an hypotension and features of peritonitis, what is the next step in the management of the patient? The answer is exploratory laparotomy. Understand this. Any penetrating injury, always the patient has to be taken to the theatre. Now, only 2 criteria. If he is hemodynamically stable, you do appropriate investigation required, then take to the theatre to manage appropriately. If hemodynamically unstable, straight to theatre and go for exploration. Okay, to arrest the bleeding and limit the injury. Understand? This is the rule. Clear? Okay, as given in page number 226 and 11th edition of Schwartz, immediate laparotomy is indicated in any patient with a penetrating abdominal injury who is hemodynamically unstable. Okay, as signs of peritonitis and evascularization, delaying in surgery can increase the risk of morbidity and mortality. Next question reads, a 43-year-old female presents with a breast lump. Okay, may not be the exact picture, could be an internet download, but the student said somewhere related to, it looks like an erythema, an inflammatory lesion, and looks like a malignant lesion. And then it could be, if it could be a staging, then definitely it's not a breast abscess. When it comes to the staging, if this is the option, then it is going to be T4D. Because we all know staging of the breast cancer is an important entrance exam question. 2 questions are always asked. One on T1MI. It is T1MI is tumor less than or equal to 1 mm or the greater dimension. Yes. And T4. And T4 is subclassification. T4A is chest wall, T4B is skin, T4C is A and B, T4D is inflammatory carcinoma of the breast. Is it clear? Either T1 or T4. For sure they are asking in breast cancer, or they can ask you the breast cancer, the treatment of choice is triple assessment. Triple assessment. A 2-year-old child accidentally aspirates a peanut and suddenly starts coughing and becomes unconscious. What is the appropriate immediate management? The appropriate immediate management would be CPR. Becomes unconscious, respiratory distress, what to do? We do CPR only. So 11th edition of Schwartz, page number 1716, a foreign body airway obstruction leads to unconsciousness, initiate CPR. See, word to word is given. Questions are taken from standard textbooks. Chest compression can help to dislodge the object. Very difficult for a student to read all the 3 textbooks. No. A faculty, a mentor has to read and to present what exactly required for the exam. That's how the training has to be. That's what we do in Dopamine. Yes. A 25-year-old man presents with an emergency department following a motorbike accident and is found to have a closed mid-shaft fracture of the left tibia. 6 hours later becomes a severe leg swelling with a disproportionate injury. disproportion to the injury and worsens the passive dorsiflexion of the foot. The pain is not relieved on analgesics. Examination, dorsalis pedis and posterior tibial pulses are present, but there is no sensation over the first dorsal web space. What is the most appropriate next step in the management? See, this is a typically of what? This is typically of a compartmental syndrome. Compartmental syndrome. This compartmental syndrome is a pressure, any lower limb compartment pressure is more than 25 mm of mercury, you should suspect. And if it is more than 30, it is definite. It is definite compartment syndrome. Treatment of choice is fasciotomy. 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 To relieve the compression, save the limb. Very, very important. As given in Bile, 28th edition, page number 444. See the number. Compartment syndrome, clinical diagnosis characterized by pain out of proportion, increasing in pain and pain on passive stretch. With paresthesia possible and paralysis and numbness and pallor are late signs. Pulselessness is extremely late sign. Very, very important question. Pulselessness is an extremely late sign. Okay. Immediate fasciotomy is a treatment of choice to save the limb. To save the limb. Understand this. A 30-year-old male patient presents with OPD with complaints of recurrent headache and nausea. MRI of brain shows what? The MRI of brain shows brain tumor. What kind of a brain tumor? Dural enhancing lesion, brain tumor. Most common brain tumor. The answer is meningioma. The answer is meningioma. As given in 11th edition of Schwartz, yes, meningioma is derived from arachnoid cap cells of the arachnoid matter arrives from the dural matter grossly on the MRI. Commonly refers to dural based tumor. Very, very important. Whether if you don't know a tumor, the answer is meningioma for an entrance question. It's a very, very famous question, meningioma. Okay. Next question. A 70-year-old patient presents with a mass in front of the neck along with the odinophagia and dyspnea. And histopathological tumor reveals cells positive for TTF1 and synaptophysin and chromogranin positive. Amyloid, this is the key one. Amyloid deposition, even if you are not sure of all this, amyloid in a thyroid. Yes, in a region of a thyroid. Yes. And the likely diagnosis. Yes, histopathology reveals. That means what? Thyroidectomy has been done. And mass in front of the neck, what is the thyroid is a mass. And is all the options related to the thyroid. If amyloid is there, is nothing but medullary thyroid cancer. Red proto-oncogene mutation, other important. Red proto-oncogene mutation. Very important. As a part, could be a part of Men's syndrome also. So medullary thyroid cancer is neuroendocrine tumor of the parafollicular cells, secretes calcium and amyloid deposits are commonly seen in the stroma. Okay, and the tumor stains positively for calcitonin, chromogranin and other neuroendocrine markers. Page number, see that, 1656, 11th edition of Schwartz. Exact word to word. Clear? So, following a building collapse, a patient with an airway obstruction undergoes a procedure as shown. Which of the following is true regarding this? What has been seen here? It's a needle cricothyroidectomy and put in a needle and to give oxygen in an emergency and put an oxygen pipe attached to the syringe. Okay, and this will be followed by what? This will be followed by tracheostomy. Clear? So, Bailey and Lau, 20th edition, very clearly says, page number 800, needle cricothyroidectomy is a life-saving procedure that allows a temporary oxygenation. However, it does not allow adequate ventilation, leads to CO2 retention. Therefore, this must be followed by a definitive airway. The surgical tracheostomy has to be done within 30 to 45 minutes. Exactly. Yes, beautifully given. So, a question on tracheostomy, okay, is most probably in any of this PG level, NEET or NEET or FMG exams. Okay, so thank you. That way we come to an end. So this question paper is on a moderate difficulty, well within the framework of an exam of surgery that is will be asked and can be asked in any of this national level PG entrance examination. Yes, so hope to see you in the next discussion in the next video. And Dopamine gives this specially curated content for you to exactly to know the framework and to prepare through the framework of an exam to answer all the question with more than 95% of efficiency. So with Dopamine, we train the same way. So I welcome all of you to register with Dopamine and to have a focused and a clear preparation to get on to the good results and the PG seat of your choice. Best wishes to all of you.